Welcome to the module on Welcome to the module on postural deviations, and a little introduction into how the thorax and the chest wall work together. So when I'm looking at posture, one of the primary goals for posture is minimizing the amount of energy expenditure on any given structure. So if I have a change in body position, I may end up with a malalignment of one or more body segments. And if that occurs over a prolonged period of time, as my body attempts to adjust or seek an optimal position, those changes can increase stress, They can result in adaptive lengthening or adaptive shortening. For example, a muscle may be lengthened to the point where the body lays down additional sarcomeres. Or it may absorb additional sarcomeres. So any abnormal posture will have an impact on what your body is trying to accomplish in terms of its daily functional activities. So one of the deviations that we see in everyday life is this position of a flexed knee posture. And I'll tend to see this clinically in patients that are a little bit older, who may have lost their extension range of motion in their knees. And what starts to happen then in this flexed knee standing posture is the line of gravity passes posterior to the knee joint axis. And as a result of this posterior orientation of the line of gravity, the quad muscles have to engage to maintain that erect position. So if I just have as little as a 15-degree knee flexed position, the quads have to increase their muscle activity by 22%. If that goes from 15 to 30 degrees, the quad muscle activity goes up to 51% of a maximum voluntary contraction. And the reason that this occurs is to overcome that moment arm that's created with that external knee flexion moment. And typically what will happen is the line of gravity will then fall anterior to the hip joint. So now the posterior glute muscles become active. And so just standing, we have this significant increase in muscle activity in the quads and the glutes, and the soleus as well, as the soleus is trying to control the tibial advancement. That energy expenditure just standing goes up significantly. So in our individuals that have this flexed knee posture, the work to stand and the work to walk is significantly elevated. So they'll tire out quickly. So then we run into this chain of events where they get tired to walk, so they don't walk. Because they don't walk, they lose mobility. Because they lose mobility, it gets harder for them to walk. So it really becomes a spiraling effect of dysfunction with this flexed knee posture. So the opposite of our flexed knee posture then is Genu Recurvatum, or a hyperextended knee. This is one in which the line of gravity passes anterior to the knee joint, and creates a large external extension moment at the joint. The problems with this recurvatum position is, and we can see in our picture, we start to have a significant increase in the posterior stress on the capsule and the cruciate ligaments. So they begin to stretch out over time. And as a result of that hypermobility through the posterior capsule, is the knee becomes quite unstable. The other problem that occurs is we get a significant compression load on the femur and the tibial plateau. So with that instability and increased compression load, we start to have a breakdown in joint surfaces. Now, why do people fall into this category? What happens with this Genu Recurvatum, this hyperextended knee position? Is sometimes it's related to a lack of dorsiflexion mobility at the ankle. So they don't have the ability to get over the top of their ankle, so their knee stays hyperextended. Another time you'll see this is in individuals that have very weak quads. Those individuals that have very weak quads won't have enough strength to engage their quads during loading response, and as in place of that 10 to 15 degrees of knee flexion that occurs in loading response, they stay in this hyperextended position to maintain this apparent stability. So those are a couple of reasons. Another reason that I'll see a Genu Recurvatum is people with chronic patellofemoral pain syndrome. And they'll stay in this position to try to unload the patellofemoral joint so that they minimize that anterior knee pain. So those are a couple of things that we may see from a sagittal plane deviation, a flexed knee posture, or a hyperextended or a Genu Recurvatum position. Another sagittal plane deviation that we may see is an excessive anterior tilt position, or a pelvic tilt position. And that's a posture when the pelvis is tilted further anterior, the lower lumbar vertebrae are forced anteriorly, and the upper lumbar vertebrae move posterior. And that's in an attempt to keep the head over the sacrum. So it typically increases the lordotic curve, and as a result of that increased lordotic curve, we end up with a increased posterior convexity of the thoracic spine and an increased concavity of the lumbar spine. Some of the problems that occur is we end up with a lengthened abdominal. So this is a postural position where we may see an increased number of sarcomeres laid down in the rectus abdominis. We also see an increase in compression forces in the posterior aspect of the vertebrae. We may equally see an increase in the compression forces through the facet joints. So the opposite of that is an excessive posterior pelvic tilt. And with an excessive posterior pelvic tilt, we get a straightening of the lumbar spine and typically a significant loss of flexibility. One of the biggest problems associated with a lack of anterior tilt or this excessive posterior pelvic tilt and that loss of that lumbar curve is the spine loses its ability to withstand a high load. So it loses its ability to absorb ground reaction forces as the foot hits the ground and that load is transmitted up through the ground. And as a result, we may end up with greater degenerative changes. Now, typically we see the nice lordotic curve through the cervical spine. But in individuals that have a forward head posture, the cervical spine loses its lordotic curve. And the head is positioned in a much more anterior location, so the location of gravity then shifts significantly forward and increases the flexion moment arm, external flexion moment arm on the cervical spine. So we end up then with a significant increase in muscle tone in the erector in the extensor muscles. We also, to keep our eyes level, we end up with a excessively extended OA joint. So the atlanto-occipital joint becomes postured in this extended position. So I have an extended OA joint with a flexed lower cervical joints, increasing the load on the nucleus pulposus through the discs in the cervical spine, maintaining chronic tension through the muscles of the cervical extenders, creating potentially ischemia, pain, fatigue. So those are all things that can occur as a result of this forward head posture. And oftentimes we'll see with this forward head posture an increase in thoracic kyphosis, tension headaches. So these are some things that I see in people that come in the office looking, with this forward head posture. Let's take a minute and talk about scoliosis. And scoliosis is really just a lateral curvature typically in the frontal plane. It can be associated with a skeletal or a muscular dysfunction. Skeletal dysfunctions resulting in scoliosis are typically referred to as structural scoliosis, whereas if I have muscular tightness and ligamentous tightness, then we end up with a functional scoliosis. We typically look at scoliosis from a frontal plane deformity. So we look at this lateral deviation in the spine. But it's important to keep in mind that, remember when we're looking at spinal mechanics, that if I have lateral flexion, then I have to have rotation that goes with it. So we typically look at this deviation in the frontal plane, but keeping in mind that I'm going to have transverse plane dysfunction as well as sagittal plane dysfunction. We can kind of look at the process of scoliosis occurring either in the infant stage from 0 to 3 years old, and which is not as common as they're still pretty flexible. We may start to see it more from a juvenile onset between the ages of 4 and 10. Where I tend to see it more often clinically is in the adolescent ages, so above 10, and we can say that adolescent idiopathic scoliosis typically will make up the majority of all of the scoliosis diagnoses, and may actually affect up to 4% of the school children worldwide. So typically the curves in a scoliosis dysfunction are named according to the direction of the convexity and their locations. So I'm looking at a lumbar scoliosis in this picture with a right convexity. This would be a right lumbar scoliosis, and a left thoracic scoliosis. And we can call that a double major curve when we see two structural curves in of about the same size. So when I look at what may cause or what hypothetically may be the series of events that creates a scoliosis event or a scoliosis dysfunction, it may occur from a variety of different sources. It could be a vestibular dysfunction where the head is offset to try to maintain level eyes. It could be a disturbance in the control of the muscle spindle. It could be a inherited connective tissue disorder. It could just be developmental instability. So there's a variety of different components that may contribute to the development of adolescent idiopathic scoliosis. When I look at what could possibly be the kind of the chain of events that would occur, we may have initially a defect in the muscular or ligamentous and fascial support system, which is not uncommon during rapid growth. So kids will end up with a growth spurt, and their muscles and ligaments have not created enough support, which then results in a lateral flexion moment. So now we have this increase in the load, the force, the line of gravity moving slightly lateral, and an asymmetrical loading of the intervertebral discs occur. So with that asymmetrical loading, the discs deform, and they create we end up with greater pressure on one side or the other, which creates a wedging of the disc. So that the nucleus pulposus will get pushed laterally, create a wedge. So one side, in our case of our right convexity, the wedging would occur on the concave side. So we would be smaller on the concave side. We'd have this disc that's wedging out laterally, and then the deviation begins to occur, so now I have this lateral curve, which is also going to be associated with rotation. So as a result of that, we get an inhibition of growth on the vertebral body on the side of the concavity, which is still in an immature spine. Because the bodies of the vertebrae are still growing in the immature spine, we end up with a vertebral body that now begins to wedge. So with that wedging of the vertebral body, the lateral curve, the head becomes misaligned relative to the sacrum, and we get a secondary compensatory curve to try to get our head back over the top of our sacrum. So now we have this adaptive shortening of the trunk musculature on the concavity, and we have stretching of the muscles and ligaments and the joint capsules on the convexity. So when I look at what that will appear on a normal flexion direction, when I have somebody lean forward, I see nice symmetry from side to side. When I have a scoliotic curve, this is a typical change that occurs with an uneven waist level, a rib hump, and a change in the shoulder height. So those are the things that we're gonna that we need to look at in even just screening for scoliosis in our adolescent population, and that is, as we just have them lean forward, is are we seeing that asymmetry occurring? When I take into consideration different postures with sitting, standing, and lying relative to interdiscal pressure, we can see by our graph that lying supine with your legs flat creates the least amount of interdiscal pressure. We can see that this position in that individual that has disc pain will probably experience minimal amount, although in this position with the knees flat typically increases the tension on the psoas, which may develop some shearing effect across the disc. So oftentimes when I have patients that come in with disc pain, I'll have them with their knees elevated to take the psoas off of tension and minimize the disc pressure. Sideline increases the disc pressure slightly, still not to a significant pathological level. We can see that standing continues to increase it, but when I start looking at these additional postures, I start to bend forward, we see a fairly significant jump. When I lean forward with a weight, it jumps to an even greater level. One of the things that is interesting is that sitting positions actually increase the interdiscal loads more so than standing. So if I have a erect sitting position compared to a erect standing position, I have a little bit higher load. Now there are some studies that have reported that erect sitting and erect standing have about the same disc pressures, but looking at it in some of the more traditional original research, we start to see a higher level in sitting, and then as I sit and lean forward, we see a greater level, and leaning forward with a weight has the highest disc pressure. So I think that we need to really consider what effect we have on our clients when we have them doing exercises in a seated position versus a standing position, what we're doing posturally in these positions, what sitting in a car in the position that we may be in a car with the vibration of the road, what impact that has on our discs. So few things to take home with, kind of take as a take-home message on what we want to look at when we're designing exercise programs, when we're counseling people with back pain, we're counseling people with residual disc pain, and have an impact on what it is that we're trying to accomplish from a postural perspective.